Class 3 antiarrhythmic drugs. Class 3 they block sodium channels, thus diminish the outward potassium channels and diminish the outward potassium current during repolarization of cardiac cells. They prolong the duration of action potential without altering phase 0 of repolarization or the resting membrane potential. Instead, they prolong the effective refractory period, increasing refractoriness. All class 3 drugs have the potential to induce arrhythmias. See, they act here. Prolong phase 3 repolarization without changing 0. And they will act on potassium. Amiodarone, dafotilide and sotalol blocks potassium channels. Now, amiodarone. Mechanism of action: they contains iodine and is related to thyroxine. It has complex effects showing all classes actions. Therapeutic uses: severe refractory supraventricular and ventricular tachyarrhythmias. It is the mainstay for rhythm and management of atrial flutter and fibrillation. It is thought to be least pro-arrhythmic of class 1 and 3 drugs. Well absorbed orally. Adverse effects are pulmonary fibrosis, neuropathy, hepatotoxicity, deposit optic neuritis, blue-gray skin discoloration, hypo or hyperthyroidism. Dronedarone. It is a benzofuran amiodarone derivative which is less lipophilic, shorter half-life, and it has a better adverse effect profile, but with symptomatic heart failure. The drug is contraindicated in symptomatic heart failure and permanent atrial fibrillation. Currently, it is used to maintain sinus rhythm and atrial flutter and fibrillation. Sotalol is class 3 antiarrhythmic drug, non-selective beta blocking activity, rapid outward potassium current known as delayed rectifier current. This blocker will prolong both repolarization and duration of action potential and lengthen the effective refractory period. Sotalol is used for the maintenance of sinus rhythm with atrial fibrillation, flutter or refractory paroxysmal supraventricular tachycardias and in the treatment of ventricular arrhythmias. This drug can cause typical adverse effects associated with beta blockers but has a low rate of adverse effects when compared to other antiarrhythmic agents. Dafotilide. It is a pure potassium channel blocker. It can be used as a first-line antiarrhythmic agent in patients with persistent atrial fibrillation and heart failure in those with coronary artery disease because of the risk of proarrhythmia. Dafotilide initiation and is limited to the inpatient setting. Half-life is only 10 hours. It is long, 10 hours. The drug is mainly excreted unchanged in urine. Ibutilide is a potassium channel blocker. Activates the inward sodium current. Drug of choice for chemical conversion atrial flutter, but electrical cardioversion has limited its use. Now, class 4 antiarrhythmic drugs, they are non-dihydropyridines, calcium channel blockers, verapamil, diltiazem. Although voltage sensitive calcium channels occur in many different tissues, the major effect of calcium channel blocker is on vascular smooth muscles and the heart. Both drugs show greater action on the heart than on vascular smooth muscles, but more so with verapamil. Verapamil and diltiazem bind only to the openly repolarized voltage sensitive channels and they decrease the inward current carried by calcium. They are dependent in that they prevent repolarization and the drug dissociates from the channel, resulting in decreased rate of phase 4. They also slow conduction in tissues that are dependent for calcium current such as SA and AV nodes. You see here, this slow phase 4 spontaneous depolarization, slow conduction in tissues dependent on calcium such as AV node. Here, here and here, all of these are the actions. They act on these calcium channels. Now, other antiarrhythmic drug, digoxin, they inhibit sodium potassium ATPase, ultimately shortening the refractory period in atrial and ventricular myocardial cells. They are used in atrial fibrillation and flutter, and digoxin can cause ectopic ventricular beats and may result in VT and fibrillation. Adenosine is naturally occurring nucleoside, but at high doses the drug decreases conduction velocity, prolongs the refractory period and decreases automaticity in the AV node. IV adenosine is the drug of choice for acute supraventricular tachycardias. Magnesium sulfate is necessary for transport of sodium, calcium and potassium. Slows the SA node impulse formation and prolongs the conduction time along the myocardial tissue. IV magnesium sulfate is the salt to treat arrhythmias. And most notably, drug of choice for treating fatal arrhythmia torsion de pointes and digoxin-induced arrhythmias. Ranolazine, anti-anginal drug, shorten repolarization, decrease the action potential duration. Extensively metabolized, well tolerated with dizziness and constipation are the adverse effects, and metabolized by CYP3A.